Welcome, welcome, welcome to probably our 8th annual Interprofessional Education Clinical Case Study Roundtable. Most of you know me as Alan Lewis, your dean here in the School of Health Professions. This is an amazing number of people. I think we have about 150 people in the room and probably another 50 people online through the live stream, which is actually a record for us. So this event is one of those events that I brought with me to Downstate when I came just over 9 years ago. I brought it from 4 institutions ago. I've been at 5 academic institutions, and my first academic institution, we did something very similar. I was not a dean there, but I was actually department head, and it was very successful. And the idea here is to have all the students here from School of Health Professions. We also have some students from nursing. Where are the nursing students? And thank you, and some students from the School of Public Health. Raise your hands if you're here. And some of them may be online. So this is the ultimate interprofessional education activity. And this is what happens in the real world. It's not often you're gonna be working on a team of a bunch of people who are just like you in terms of their training and their discipline expertise. It's more likely you're gonna be working on a cross-functional team to understand different perspectives from other clinicians who are trained similarly but have a little bit different worldview. You know, a PT's worldview is a little bit different from a public health professional's or nurses. So the beauty of this event is that you all get to sit together ultimately and think about the kinds of interventions and things you will offer for this really thorny case that we've laid out for you today. And it really is great because you all get to do it across your silos, across your disciplines. And this event is one of those events that we do in our school because, you know, in the School of Health Professions, we try to give you students content outside of your classes. Because the reality is you could have gone to any other school in New York City in your discipline. As long as it was an accredited school, you'd be trained okay and be successful in your discipline. But we here at Downstate and in our school try to do things a little bit different, give you a distinctive advantage by giving you content outside of your classes and courses. So that's why we're glad so many people are here, because that really gives you extra horsepower going forward so that you can not only be a great clinician when you leave or public health professional, you can also be a leading thinker and influencer in your field because you have some other skills overlaid on top of your discipline-based expertise. So that's the beauty of opportunities like today. So again, thank all of you for being here. I know this event required a cast of thousands to plan it, and I don't have the list, but I know we have people from public health. I think there's a list forthcoming later, but we have faculty from public health who are here, faculty from nursing who are here, faculty from health professions, and staff from health professions from every program that have been involved in putting this event together, including the Dean's Office. Assistant Dean Bones is the point person for this event in the Dean's Office. Dean Bones, raise your hand. Dean Bones. You all know him. He's the tallest guy in the building. And so anyway, we're happy you're here. I'm talking way too much. So I'm getting ready to give the mic up so you all can get down to business and do the learning that is so important in an activity like this. Again, welcome. We're glad that you're here. Public health students, nursing students, and students from all the disciplines and health professions. So have fun, enjoy the activity. This is what it's all about, you know, learning how to work across professional lines. So with that, I'm going to turn the mic over to Dr. Crystal Brewington, one of our faculty in occupational therapy. Thanks again for coming.
Thank you very much. Good afternoon. Just to reiterate what Dean Lewis was expressing, I would like to welcome everybody to the Interprofessional Case Study event. Thank you to all faculty members involved, and most importantly, the students for your contributions and participation here today. I'm Dr. Brewington, OT faculty, and the chair of the Interprofessional Case Study event. In a nutshell, interprofessional education occurs when students from 2 or more professions learn about, from, and with each other to enable collaboration and improve health outcomes. We have students from all 8 schools, well, the schools of health profession, nursing, and public health, as Dean Lewis stated. Interprofessional case study events highlight the importance of teamwork and collaboration across disciplines and are essential for the complexities of modern healthcare. They help to improve patient care, reduce medical errors, enhance efficiency, holistic approach, as well as professional growth and cost effectiveness. Interprofessional can also be coined as interdisciplinary, multidisciplinary, or intercollaborative practice. Overall, it's a patient-centered care that is critical to keeping patients healthy, partnership with the patient at the center, shared decision-making, respect from everyone, bringing their knowledge to the table. And with all the disciplines being involved in our case studies today, I hope that you all learn from each other and have a very fruitful experience and conversation. So we will get started. Dr. Condon, if you can come up and read the case study for us, please.
Thank you. Okay. So, welcome everyone. So happy to see all of you here. We wrote this case because we thought it was a great opportunity for folks to look at a relatively unusual but highly serious condition. And you all did a great job. I got a chance to review your slides a little while ago. So thank you so much for the effort that you put into it. Today we're talking about Veronica Clark, who's a graduate student from Guyana studying pharmacy at one of the universities in New York. She's 29 years old and she has had one pregnancy. Her history at the time of her pregnancy was unremarkable. She had no personal or family history of cardiovascular disease. She had an uncomplicated pregnancy with no concerns or complications until 34 weeks. In her family history, she had no hereditary heart conditions. These are important things to keep in mind about the, about the condition that we're looking at. So she presents to her midwife and OB team at 34 weeks with complaints of mild fatigue and shortness of breath, which she attributed to the normal common discomforts of late pregnancy, which is really, really common. She also noted some swelling in her ankles, but was reassured that this was typical for this time. On exam, during the examination, her blood pressure was slightly elevated, but there was no significant cardiac finding. She had a grade 1 murmur, which is also common in the third trimester of pregnancy, when plasma volume expands as the normal adaptation to pregnancy. An ECG was performed, but was interpreted as normal. She was advised to rest and monitor her symptoms. After an uncomplicated birth, Veronica's symptoms persisted and she experienced increasing fatigue and worsening shortness of breath. She returned to the clinic at 6 weeks postpartum for routine care, where her symptoms were attributed to postpartum recovery and the adjustment to motherhood. So in this case, we have a misdiagnosis because it's really typical to dismiss people who present this way because the pregnancy sort of masks the very loud symptoms that you're seeing here. Despite her ongoing symptoms, no further cardiac evaluation was performed. Over the next few weeks, Veronica developed worsening dyspnea, orthopnea, and significant pitting lower extremity edema. She sought care at an urgent care facility where a chest x-ray revealed cardiomegaly. So for the diagnostic workup, an echocardiogram was performed, revealing severe left ventricular systolic dysfunction with an ejection fraction of 25%. Blood tests showed elevated BNP levels, confirming heart failure. Her final diagnosis was peripartum cardiomyopathy after weeks of various clinicians having missed the diagnosis. For management, Veronica was admitted to the hospital and started on diuretics and ACE inhibitors and beta blockers. Lifestyle recommendations included sodium restriction and fluid management. And after a few days, her symptoms improved significantly. In terms of the outcome, she was fortunate. At the follow-up appointment, her ejection fraction improved to 45%. She was counseled about the condition and the importance of regular follow-ups. She was educated on the signs of heart failure to monitor for potential recurrence. So in terms of the discussion on this case, due to persistent racial and socioeconomic health disparities, PPCM is a significant driver of maternal morbidity and mortality, especially in communities of color. This case underscores the importance of recognizing the signs of peripartum cardiomyopathy early. Misdiagnosis by attributing signs and symptoms to normal pregnancy adaptations and common discomforts can lead to progression to heart failure emphasizing the need for heightened awareness among all healthcare providers, including those outside the obstetric arena. Thank you. Yeah.
Thank you very much. All righty, so we're going to get started. I'm going to ask the Health Informatics Program representatives, to come up, please.
So this one goes to the next one, right? Oh, hold on, we are missing one person. Where's Lens? Oh, you do this part. Okay, I could do this part. Okay, hi everyone.
Hello.
My name is Fariha.
I'm Nigel.
We're from the Health Informatics Program, and we're going to talk about how health informatics could have helped in this situation. This is just a slide of the case study that was read. Veronica, 29 years old, from Guyana, and some of her symptoms and a diagnosis at the time was considered typical pregnancy symptoms. This is a clinical decision workflow, and it shows Veronica underwent a standard clinical assessment where ECG appeared normal and her slightly elevated pressure was considered wasn't considered alarming. Despite reporting fatigue, shortness of breath, and swelling, her symptoms were dismissed as typical pregnancy and postpartum changes. An ultimate assessment was no major concern. With no systematic way to flag high-risk symptoms and no follow-up cardiac evaluation, her condition worsened until it reached a critical stage. The outcome of that was structured clinical data and integrated warning symptoms led to a delayed diagnosis when early detection could have prevented complications. Veronica went for her 34 weeks checkups with symptoms like fatigue and shortness of breath. So this is a diagram on the right, and it shows on the top, it shows what actually happened, and the bottom, it shows what could have happened that could prevented this. So 34 weeks pregnant, she went to the doctor. The doctor didn't think that she should get a cardiac evaluation. And then she went home, gave birth 6 weeks later, went to the emergency room, and they found out that she probably had some cardiac issues. So the bottom part shows if there was some AI implementation in the maternal department, her symptoms could have been flagged. If her symptoms was flagged, the doctor would have considered to do a cardiac evaluation. She could have had a normal pregnancy, and she could have followed up with just telehealth appointments. And I did put a rest in peace icon there because this is a serious issue, and some women do die from this issue.
So a significant proportion of Black women are affected by PPCM due to missed or overlooked diagnosis occurring at a higher rate compared to other racial groups. So the socioeconomic barriers such as lower income, limited access to quality of healthcare, inadequate insurance coverage, and disparities in health education further restrict Black women from receiving timely and comprehensive care. The lack of diversity in medical research and clinical trials also contributes to the underdiagnosis of PPCM in Black women. While reducing health disparities is crucial, ensuring that all patients receive accurate and efficient diagnosis are important for effective patient care. One of the main roles of informaticians is to look at how data is stored, transferred, and transmitted, ensuring seamless, comprehensive data integration between different providers and systems. So in Veronica's case, she has seen different doctors at different times, each addressing different symptoms. which contributed to her delayed diagnosis. If the EHR was properly integrated, her providers would have been able to share her status and her symptoms over the course of her visits. So implementing informatics and solutions in clinical practice, AI scans EHRs to identify high-risk patients based on pre-existing conditions like pregnancy history and cardiovascular markers. Machine learning models can trigger automated alerts for physicians if postpartum patient reports PPCM-related symptoms. AI-integrated wearable devices monitors heart function, real-time alerts for abnormal heart rate, blood pressure, and oxygen saturation. Blockchain technology also secures patient-shared data. So if Veronica was wearing these wearable devices, her providers would have known her status earlier to prevent misdiagnosis.
So in conclusion, Veronica's diagnosis of PPCM came weeks too late after multiple missed warning signs, despite receiving Diuractis, ACE inhibitors, and beta blockers, alongside lifestyle modifications. Her case underscores a critical failure in early detection. While her ejection fraction improved to 45%, the delay in diagnosis put her at unnecessary risk. Had health informatics tools been in place, CDSS alerts could have flagged her persistent symptoms, triggering an early cardiac evaluation. AI-driven risk assessments could have identified her as a high risk, and telehealth monitoring could have ensured her worsening condition was addressed before reaching a crisis. But Veronica's case is not an exception. It's part of a larger systematic issue: racial and socioeconomic disparities. Implicit bias and fragmented clinical data continue to delay life-saving diagnosis for many women. PPCM is often overlooked, but early detection can mean the difference between life and death. To prevent more cases like Veronica's, we need a structured, data-driven approach, one that integrates AI-driven alerts, predictive analytics, and equitable maternal health care. Because missing the signs isn't just an oversight, it's a matter of survival.
Thank you very much. We'll have students from the Physician's Assistant Program come up next, please. Thank you. To the live stream. I have another mic.
I'll let her give you the thing first, so you can go. Okay, so we're going to be presenting on behalf of the PA program. So I'm Etty. I'm Jasmine.
I'm Chris. Is this working? Okay, good.
So we're just going to tell you a little bit about the program, a little bit about what a PA can do, and then proceed to discussing the case. So PAs are known as physician assistants, also known as physician associates. They're interchangeable. And we're nationally certified and state licensed clinicians who can practice medicine in every specialty and setting. So we're trusted because we're well educated, and we're trained in various different settings, various different fields. And PAs are dedicated to expanding access to healthcare and transforming health and wellness through patient-centered, team-based medical practice. So essentially, imagine that I'm an OB PA, and I would follow my patient throughout her pregnancy, through delivery. And then in this specific case, I would pass my patient on to Chris, for example, as a cardio PA, who would then follow the patient throughout everything involved in cardio, run an echo, an EKG, everything involved in that, who would then treat the patient and then send his patient to Jasmine as a primary care provider to maintain follow-up care. So essentially, PA's roles, what can we do? So specific duties depend on the setting where we work, the level of experience that we have, our specialty, and state laws. So more specifically, PAs can manage patients of all ages: pregnant women, non-pregnant women, men, children, really anyone. And how we're going to work a patient up is we're going to start with a comprehensive history and physical. And we're going to do vital signs, weight, height, weight, blood pressure, temperature, really everything involved in that. Then we're going to get our differential diagnoses. So we're really going to be able to see what we're thinking based on how the patient's presenting, their chief complaint, everything involved in that. And we're going to order our diagnostic tests. So we're going to order labs, imaging, anything involved in that. And then we're going to be able to interpret those results. So we're going to look at the labs, we're going to look at the levels, we're going to look at the imaging, we're going to look at the cultures. And based on that, we're going to interpret what we think is wrong with the patient. Then we're going to treat the patient. So that includes multiple different methods. We can refer them to other practitioners. We can prescribe medications, including scheduled 2 to 5 drugs, which are essentially controlled substances. And we're also going to want to educate our patients. So we're going to encourage them to ask questions. We're going to provide pamphlets and other resource material. Then lastly, we're going to be able to perform procedures, assistant surgeries, make rounds in hospitals and nursing homes, and we're going to do clinical research.
All right, thank you. So this is some pertinent case information. Oh, thank you. Some pertinent case information. The first thing that we're going to do as a cardiology PA in this case is review the history of present illness for the patient here. So we've already seen this at the beginning of the conference here. I do just want to make some highlights that as a PA would stand out to me in this case. So we see here that the patient was G1P0 at onset of symptoms. So we see the patient had fatigue, shortness of breath, some mild ankle swelling. As the disease progressed into PPCM and eventually heart failure, we noticed that the shortness of breath got worse. So we see dyspnea, we see orthopnea. Some other, oops, that was me. We see as well as some pitting edema. So the ankle swelling got worse. So that's when you press on the lower extremity in this case, and we see that there's some excessive fluid in those legs. So the rest of this part of the case, diagnosis, management, significance, we'll go into in a moment, and kind of the ideology behind these things. So next, we're just going to talk about just a few words on peripartum cardiomyopathy. So peripartum cardiomyopathy occurs toward the end of pregnancy or within several months following delivery, so either before or after delivery, and it presents as heart failure secondary to left ventricular systolic function. It can be associated with gestational hypertension or twin pregnancy, so some specific circumstances there. Complete recovery ensues in some patients, but progressive disease can occur and can be fatal unless cardiac transplant occurs. It's kind of split. Recurrent pregnancy is not recommended as this condition can recur and can be fatal, so we would tell our patient, be careful getting pregnant again. This can re-exacerbate these issues. So we see the patient, we start meeting with them, we're face-to-face with them, we're going to talk about patient history. We're going to start asking questions. So the idea behind this is since we can't have a direct etiology of this disease, we do know that it leads to heart failure. So that's how we're going to see these signs and symptoms present to us. So some of these things include chest pain, dyspnea on exertion. So when you're exercising, reproducing dyspnea with activity, we're going to notice that the patient might complain of palpitations. So they might feel like a skipped beat, as well as lightheaded, syncope, dizziness as a result of this heart failure. For all these symptoms, we're going to talk about with the patient when they occur, so when their onset is, how long they occur, etc. And these last 2 bullet points here, family history and previous cardiac issues, are very important to ask the patient about because these 2 things are basically things that you want to rule out from your diagnosis. Because if they have underlying cardiac issues, we know that it's likely not peripartum cardiomyopathy. And that's what we're going to get into with regard to our diagnostic criteria. So I'll hand it over to Jasmine.
All right, perfect. Thank you, Chris. Okay, so as PAs, you all know that we will be conducting physical exams. So in our physical exam, we expect to see these findings. So first, we will inspect. We notice that there's jugular venous distension, which is basically when you have increased pressure, venous pressure due to heart dysfunction. We'd also see some peripheral edema, as Chris mentioned earlier, due to fluid accumulation. We'd palpate, we notice that the point of maximal impulse of the heart will be laterally displaced. We'd also palpate our edema to check for pitting, as Chris mentioned earlier again. And we'd also notice that there will be enlargement of the liver, and we'd palpate that as well. And upon auscultation or listening, we'd hear abnormal extra hard sounds such as S3 and S4 due to the volume and pressure overload. And we'd also hear abnormal lung sounds such as rills. Okay. And now in doing our diagnostic workup, we would first order some blood work. So we do a comprehensive metabolic panel, a complete blood count, and a BMP, which would be elevated in our patient's case. We'd also perform and interpret diagnostic tests such as ECGs, echocardiograms, as well as stress tests. We will assist cardiologists in performing procedures such as cardiac catheterizations, and we would also follow a specific criteria to diagnose our patient with peripartum cardiomyopathy. So we'd notice that there is an absence of recognizable cause. We'd notice that there's an absence of prior heart disease, which is extremely important, as Chris mentioned. We check to see if they developed their heart failure in the last month of pregnancy or 5 months postpartum. And with the echocardiogram, we would see if there's a decreased ejection fraction, less than 45%, or a shortening fraction of less than 30%. Okay, and management. So how do we treat peripartum cardiomyopathy? So we'd give our patient ACE inhibitors or angiotensin II receptor blockers, ARBs, and those work by causing systemic vasodilation. We'd also give beta blockers, which would help lower the heart rate and contractility, ease, what the heart is going through. We'd give diuretics for fluid overload, some anticoagulants if there's an arrhythmia present to prevent myocardial infarction or heart attack. We'd assist in transplant if it's needed, and we give our patient education, right? So we let our patient know if you are deciding to have a future pregnancy, be aware that this may come up again, as Chris mentioned. And we just want to emphasize having an active lifestyle, taking in a lot of fluids, limiting their salt intake, and adhering to their medication. And then at the bottom, we just have some pictures of what peripartum cardiomyopathy may look like on ultrasound. And yes, thank you.
Thank you very much. Next, we'll have students from the College of Midwifery, Please come up.
Good afternoon, everyone. We are from the Midwifery School. My name is Aisatu.
Hi, evening, I'm Leah.
Okay. We're going to start our presentation by talking about what is midwifery, and then we will dive into the case study. So, who is a midwife? Midwives, usually when we say midwife, people associate them to people that help people to give birth, but we do more than that. Midwives are licensed independent healthcare providers with prescriptive and referral authorities, and they could hold master's degrees, doctorate, or national certification. Midwives provide care, comprehensive primary hair care to all ages, including from menarche through menopause and beyond. They provide reproductive and GYN, including preconception, pregnancy, childbirth, that's during delivery, postpartum, and also newborn care. They also manage miscarriage, abortion, treatment, family planning, and STDs. Additionally, they can also conduct GYN exams, nutritional counseling, parenting, and patient education. So why do people choose to be cared by midwife? Midwives, they stand out in their dedication to listening to the patient and encouraging them to participate actively in their care. They plan the care with deep consideration of the patient's feeling, emotions, values, overall well-being. Midwives are committed to healthy choice throughout the person's lifespan. They work in partnership with the client and their family and help them select the best care, empowering individuals to be integral members of their healthcare team. We provide holistic wellness education. Where do midwives practice? So midwives practice in various settings. This could be in clinics, in hospitals, in birth centers, as well as in homes, providing home births to people that choose to deliver their babies at home. Who can get midwifery care? So there is no specific, there's no limit. They provide care to all kind of people. It's all inclusive, based, including all gender identification and sexual orientation.
So for this patient, midwives would be doing the same screenings that's recommended that everybody does during prenatal. So we would be doing the regular checkups on the fetus as well as the maternal patient. So we would be doing the H&Ps, the labs, fetal heart rates, ultrasounds. For this patient, since she was fine for the beginning of the pregnancy, when a patient comes in like this at 34 weeks, we would have wanted to initially rule out preeclampsia, gestational hypertension, anemia, or make sure she's not having a pulmonary embolism. So early detection would have been optimal, but with this patient, what was missed was we didn't, or whoever was caring for her did not follow through, which happens a lot with people. So we know this patient is Guyanese. That doesn't tell us her race, but people from that Caribbean area, they're either going to be usually Afro or Indo descent. So she falls into all of those categories of who would have a higher risk of this PPCM. So the patient came in at 34 weeks. We misdiagnosed this patient. Likely it could be attributed to her race and socioeconomic. That's just what it comes down to usually. So timely intervention would have been appropriate for this patient. As midwives, we would have ran the labs, did the initial rule outs. When she had continuation of the symptoms, we wouldn't have sent her home. We would have did the EKG, and even that doesn't rule out this condition. So what we would have done is continue to listen to her and get her a cardiac referral, because although many people don't know our scope, we have to know our scope very well, because we're not cardiologists. So we would have referred her for cardiac and also for MFM once she got that diagnosis, because she did have 2 out of the 3 of these criteria to meet PPCM. We're missing that LVEF less than 45%. So if we could have caught this sooner than we did, which was during her postpartum, we would have maybe prevented that severe 25% LVEF. So once this patient is diagnosed, we would have co-managed the care, and this depends on the setting that the midwife is in and the severity of the disease process for this patient. So the midwife may be co-managing with MFM or with the cardiologist as well if it's in the hospital. Some midwives do manage high-risk births as well. So it just depends on the setting. And even if this patient is severe, depending on the midwife and where they are, midwives generally do follow with their patients, even if she's just going to stop in and see this patient during labor, just so this patient could see a familiar face. That could probably happen too with a midwife. It's also important to note that around this time at 34 weeks, these visits can become very fetus-centered. So a lot of times the patients come in and we go straight to the belly and we listen to the fetal heart tones, and we don't really assess the person in front of you. So just remember that it shouldn't be a fetus-centered visit. There's 2 patients there, and if we would have did proper exams, we might have found jugular vein distension. We would have seen the edema, so things like that. So midwifery management, as I said, intrapartum, it would look different depending on the setting and the individual. But if this patient is not severe and they're being co-managed by midwives in a hospital setting, we could do, usually people who seek out midwife care, they have an idea of what they want their birth to be. They may want low interventions. They may want more independence during birth. Maybe they can move around and eat and not be very restricted. So we can still give them that type of environment. The midwifery model can be used in any setting. So we can apply it here as well, especially if this patient, if she was diagnosed before postpartum, we would have been limiting her fluid intake and all of those things. So with co-management with MFM, this patient may have been able to have not been on continuous IV fluids during labor. Maybe they wouldn't have been in the bed the whole time, hooked up to lines. Maybe they could have had some independence to move around, to take in like light meals, liquid diets. So that's, they can still have some midwifery type of environment in this, with this condition as well. It just depends on how severe it is. So we would minimize those medical interventions because we don't want them to have a C-section anyway with this condition because there's higher risk of poorer outcomes. So that's where the midwives would help with this co-management.
During postpartum period, the midwifery management will include educating this patient about the disease management. This includes compliance with medication as well as follow-up, making sure that the patient have the right referrals that she need. It will also we'll also assess the patient for need for like social worker if there is any signs of depression. We also assess the patient for need for nutritional counseling, such as if they need WIC, because the management of this disease will include lifestyle changes, which will involve nutrition, exercise, diet. So we will look into all that, and it will be a collaborative and a shared decision-making with the patient. When we are talking about family planning, like for future pregnancies, if this patient desire to get pregnant in the future, we will make sure that the patient knows the risk that is involved, which it's said to be 30 to 50% increase recurrent risk, and will ensure that the patient get the right care that he needs before he embark on another pregnancy. In terms of contraceptives, we will talk to these patients and ensure that they educate them on the right contraceptives to choose. And in terms of looking at cardiac risk, and we'll probably recommend them to use copper IUDs that are non-hormonal IUDs and progesterone-only contraceptives that have lesser risk in terms of cardiac complications. We'll also make sure that, as I said, they have a referral, and for future pregnancy, they have a consultation with maternal fetal medicine if they wish to get pregnant in the future. Okay, these are also midwifery considerations. We will look into like how these patients diagnosis was missed by just assuming that those symptoms or signs that she was complaining has to do with normal physiological changes during pregnancy. We'll ensure that we look into other diagnoses to exclude other complications, other diagnoses like preeclampsia, hypertension, and ensure that the patient has the right diagnosis. Also look into the social determinants and also the hierarchy of the patient's need. And it's also very important we look at race and disparity as people, Black people that are diagnosed with PPCM have, that are not diagnosed on time have a long recovery and poorer prognosis, including mortality. Patients' potentials, like we also assess these patients to ensure that how they are taking the diagnosis, they may be disappointed, and when the risk out of the patient's potential disappointment, when risk out of midwifery care should be addressed. Like we should ensure that these patients, when they are diagnosed, to know how they are taking this diagnosis and what are some of the things that they are going through.
And lastly, we would do lactation preparation and support because some of our, or a lot of patients want to breastfeed or lactate. So some medications they can't have, some they can have postpartum, but not during the pregnancy. So we would refer to an IBCLC, and we would just assist with the lactation. But most importantly for this case, we just want to highlight that despite this being a rare condition, this happens with common conditions based on providers not listening to patients, especially patients of color. So that's really what happened here, is the misdiagnosis based off of providers not listening. And that's one of the reasons why people go towards midwifery, especially people of color, because midwives have been taking care of us for generations. So that's how midwives can be involved in this.
Thank you very much. We'll next have the students from the Diagnostic Medical Imaging School.
Can you hear me? Yeah. Okay. Good afternoon, everyone. My name is Hannah Rajay.
My name is Yushan Wu.
And we're from the Diagnostic Medical Imaging Program. So we're going to be showing you how we use echocardiograph to diagnose postpartum cardiomyopathy.
So what is echocardiogram? It is a non-invasive, non-radioactive ultrasound exam that uses very high-frequency sound wave to create images of the heart. And we have different types. We have transthoracic, it's done by the sonographer. And we have esophageal, that is usually done by the cardiologists, and also stress echo. So we use basic modes, includes 2D, which helps to assess the cross-sectional heart views. And we also use MO. Here you can see the images there. We push these cursors one single line at the level of the aortic valves. So we create this image of the, you see different levels of the heart, the right ventricle, aortic valve, and the left atrium. And we also use this continuous wave Doppler, color Doppler, post-wave Doppler to gather the blood flow and the velocity. So here's the images you can see here. We will trace the waveform, and the machine will calculate the aortic valve VTI, and we can assess whether the mitral valve will have stenosis and things like that.
Okay, so there's echocardiograph obviously has a huge role in diagnosing postpartum cardiomyopathy. So one of the reasons why they go for ultrasound is because it's safe. There's no radiation. The moms could have it before pregnancy and after pregnancy. They won't have to suffer any type of radiation. Second role is the hallmark of postpartum cardiomyopathy, which is left ventricle systolic dysfunction. Echo is the gold standard for calculating the ejection fraction, which in this case would be less than 45%. Our patient had 25%, but based on guidelines, females should have a range from 55% to 75%. So for her to already have less than 45% is already below the normal range. We also assess heart chamber size. We look at the left ventricle and the right ventricle. We look if there's any dilatation, which in this case, there would be a dilated left ventricle. We also look at wall motion. So echo could see if there's any regional or global hypokinesis, which is reduced wall movement. So for this case, it would be global hypokinesis. So it's an overall reduced wall movement. And we also use it to exclude any other causes prior, so we could see if there is another problem that could have led to this. There could be congenital heart disease. We could have valvular heart disease or any previous cardiomyopathies that this patient wasn't diagnosed before coming to us. So we could rule out if there is another problem that could have led to the symptoms that she is showing. Okay, so finally you get to see some videos and clips. But these are, as I mentioned before, the hallmark of cardiomyopathy, postpartum cardiomyopathy, the left ventricle systolic dysfunction. So I wanted to show you a video, hopefully. Oh no, what happened? Go back. How do I go back? Okay. Is there a way I could play the video? Okay. So for our first case, this is in different views. We have in plaques, short axis, apical 4 and apical 2. You could see that the heart is contracting well. The ventricles look normal in size. This is 60% ejection fraction, which is within the normal range of what a person should have. But now when you look at, oh, you know what? I'm so sorry. I'm doing the opposite of what I should be doing. Okay, yeah, me. Okay, so for case 2, we're looking at the same views, the same 4 views, but in this, I don't know if you can see because it's kind of light in here, but you could see that the left ventricle is dilated compared to the first one. You could also see that the walls are not contracting as much as the first video, and we don't see as much wall thickening, and overall, you see how dilated the left ventricle is. Finally, to the slide. So as I mentioned before, there's going to be left ventricle dilatation. I wanted to show you an image because you could see how dilated the left ventricle is. We also we gave the measurement 5.2 centimeters. That is, below that is what should be normal for females. Above that is abnormal. So the patient, sorry, yes. Let me just move on.
So other secondary findings in PPCM, patient might have a dilated right ventricle, which can lead to a systolic dysfunction. And also they will have elevated pulmonary pressures because as we mentioned before, the patient's left ventricle has this systolic dysfunction. So it will lead to the pressure backup in the pulmonary. So it will lead to the pulmonary pressures increase. And also they might have this mitral regurgitation, which is the blood flow will going back during systole. So in normal patient, in systole, the mitral valve is closed, so you will not see any blood going forward or backwards. But in patient with PPCM, because the left ventricle is dilated, so it pulls the valve apart. So you will see this regurgitation right here. This color is during systole, so we see this color going back. Another finding is they might develop into this thrombus in the apical. Because due to this ventricle is dilated, it's now akinesis, which means the ventricle is not contracting. So it will lead to the blood stays there and create this thrombus. I think we have the videos.
I don't think the video.
Maybe, okay. But you can see that's echogenic part at the apical, and it's very circular, and you can see give you the clues that's the thrombus forming there. So what are other roles of echocardiogram? It can help to monitor the progress of the patients, whether they get any improvement after the treatment. So they have to follow up regularly doing several of the echocardiogram. And they also have to assess the persistent dysfunction. And also it can help to stratify how severe the disease is and to stratify the risk for the complications.
It also basically it helps guide physicians and doctors in knowing what to provide, what type of medication to provide, either to provide ACE inhibitors, beta blockers, or if they need in more severe cases, they would have to give them mechanical circulatory support. And finally, it helps predict recovery. So these follow-up ultrasounds, we could see if the left ejection fraction improved or it gotten worse. Usually with patients that have better ejection fraction have a better outcome. Patients that come again and have worse ejection fraction usually have a worse outcome. And that's it. This is our references.
Thank you.
Thank you very much. Next, we'll have students from the occupational therapy program. Who wants this first? Who's talking first? Thank you.
Good afternoon, everyone. My name is Giovanna.
Kristen.
Justine. And I'm Jasmine. And we're going to present on the interprofessional clinical case study for OT.
All right. So starting off with the occupational therapy scope of practice, an occupational therapist treats clients through a holistic approach that involves focusing on their physical, emotional, mental, and spiritual well-being in connection to the meaningful occupations in their lives. Occupations can be defined as activities that people do every day to give life meaning and purpose. The practice of occupational therapy means the therapeutic use of everyday life occupations with persons, groups, or populations to support occupational performance and participation. Occupational therapy practice includes clinical reasoning and professional judgment to evaluate, analyze, and diagnose occupational challenges and provide occupation-based interventions to address them. So some approaches that we felt were relevant to Veronica's case include energy conservation techniques, psychosocial support, and activity modifications.
So the occupational therapy role in cardiac care, after being discharged from the hospital and becoming medically stable, Veronica would most likely be referred to occupational therapy in the outpatient setting. So OTs have a distinct role in the outpatient cardiac rehab programs with clinicians working within an interdisciplinary team to address the needs of clients with cardiac conditions. OTs evaluate an individual's ability to perform meaningful ADLs and IADLs in a functional manner, develop client-centered treatment plans, and collaborate with the client to establish goals and provide education to manage their condition at home and in the community. So a little bit more about what Gia was talking about, energy conservation techniques. So OTs can teach patients how to perform activities of daily living and instrumental activities of daily living efficiently to reduce strain on their heart and to reduce fatigue. Psychosocial support, OTs can address common reactions to sudden cardiac diseases, and that could be expressed as anxiety or depression by providing coping strategies and promotion of participation in meaningful activities. Home and activity modifications. So OTs can recommend adjustments to the patient's home environment as well as activity modifications that can be used to reduce physical strain on the heart. So treatment considerations. So throughout Veronica's care, we want to take a look at her vitals. So throughout the sessions with Veronica, vitals should be regularly monitored in the early stages before treatment to proceed in case of recurrence. So that would be heart rate, blood pressure, and oxygen saturation, as well as symptoms. So some of these symptoms such as dyspnea, orthopnea, edema, pain, fatigue, and reduced mental status can also indicate a reoccurrence of heart failure. And some activity considerations. So throughout treatment, we want to make sure to monitor the rate of the activities that she's doing, the resistance used during these activities, and isometric muscle use, because all these things increase blood pressure and we want to not do that.
Moving on to energy conservation techniques, an occupational therapist can provide education on energy conservation techniques to help Veronica manage fatigue more effectively, properly care for her baby, and complete daily tasks. This may include prioritizing tasks that require more energy earlier on in the day, pacing activities that are physically demanding, and incorporating rest breaks to prevent overexertion. So by modifying her environment, such as placing baby care items at waist level, this can reduce unnecessary movement. Veronica may also benefit from adaptive equipment. So as we see on the bottom right, we have a shower chair or a long-handled tools can also be implemented to decrease exertion and also assist in her recovery from the birthing process. Additionally, breathing techniques like pursed lip breathing can help improve endurance and reduce shortness of breath. And these strategies together will support Veronica in participating in her daily activities while minimizing fatigue and promoting overall well-being. Pursed lip breathing is a technique that helps control breathlessness. It improves oxygen exchange and saves energy. So by inhaling through the nose and exhaling slowly through pursed lips, it reduces breathing effort, prevents fatigue, and promotes relaxation. This technique slows breathing, keeps airways open longer, and makes daily activities feel less tiring, which can help her stay more active.
Occupational therapists can also provide psychosocial support. So the chief concerns in this case are feelings of depression due to the loss of independence after diagnosis, emotional distress after the misdiagnosis, and adjustment to the role as a mother of a newborn. So occupational therapists can educate the patient on coping strategies, which can be used for stress management and emotional regulation. Strategies include practicing mindfulness, journaling, relaxation techniques, and grounding exercises. And after she learns various coping strategies, she can pick the ones that best suit herself to use when she experiences any stress or anxiety. Occupational therapists can also address social supports. So as a new mother with a diagnosis of PPCM, she can experience worries taking care of a newborn. And it's important to encourage her to identify her social supports, including family and friends. Having these supports allow her to communicate any needs, such as asking for help with household tasks, emotional support, or with childcare. And she can also join support groups for new mothers to share with others who experience similar challenges. And with the role of being a mother, student, and individual with a health condition, it can be stressful. So occupational therapists can work with her to balance and prioritize her roles and responsibilities, adjust the expectations she has on herself, and create a manageable way to complete tasks, such as through scheduling and planning.
Okay, now moving on to the idea of activity modifications. So an occupational therapist could educate Veronica on the idea of task simplification. So as a mother of a newborn, there are many tasks that require exertion, which include carrying or handling the child, changing diapers, and feeding. So some specific recommendations can include using a changing station at waist height, keeping supplies at arm's reach, and changing diapers while seated. So during a stressful time like this, these might seem as simple changes you can make, but you may not think of this on the spot. And just utilizing the proper body mechanics and engaging the core and bending at the knees when lifting up the baby. And as for diaper changing, due to her diagnosis, she is at risk for increased heart strain. So from prolonged sitting, lifting, and walking, it would be recommended to Veronica that she can keep diapering supplies in multiple locations in order to reduce movement and to engage the core and bend at the knees. And she can also sit whenever possible when performing these activities. Overall, we are working to reduce exertion and prevent shortness of breath. So the idea of just optimizing your setup to avoid unnecessary lifting. Then we can look into task breakdown. So breaking down each task into more smaller, manageable steps will help Veronica preserve her energy and prevent any overexertion and allow her to care for not only herself, but also her newborn more efficiently. So this idea is crucial for energy conservation, increasing safety, and overall our main objective, increasing her functional independence. Some sleep recommendations include that she may benefit from sleeping with her legs elevated, wearing compression garments, and regular movement both at home and during school. When getting up out of bed, it would be recommended that she could utilize the log roll technique and push up with her arms in order to reduce overexertion. As for handling and carrying strategies, it would be encouraged that she uses a lightweight baby carrier as seen here. This would evenly distribute the weight of the child. And additionally, she can carry the baby at chest level and close to the body in order to reduce strain and prevent imbalance. And as mentioned previously, if Veronica lives with a partner or any family members, it would be beneficial to educate them on her condition and the techniques recommended. This will help with the idea of task breakdown, identifying her symptoms, and prioritizing any tasks.
So bed transfers, so this is what Kristen was talking about, the log roll transfer. Bed mobility is a domain under occupational therapy. It is the transition from in the bed to out the bed. So doing it like this minimizes exertion, which reduces strain on the chest muscles and heart. Slowed controlled movements also reduces the risk of dizziness, shortness of breath, and falls. And also ultimately what Veronica's goal is to increase her functional independence, and this is what this can do. And lastly, occupational therapists can recommend home modifications. So this includes the reorganization of her space. Essential items should be moved to ensure they are within reach to reduce any unnecessary exertion. So commonly used items should be above waist level to reduce strain and overexertion. And for fall prevention, it's important to remove any tripping hazards. That could be toys, rugs, or clutter, being that PPCM-related fatigue may impact balance. She can rearrange her bedroom. So if she prefers to breastfeed or sleep close to her child, her home can be rearranged to have her child sleeping in the same room. And they can either engage in co-sleeping if approved by their pediatrician, utilize an attached crib, or move the crib in the bedroom. This would reduce the energy and time needed to get in and out of bed. And lastly, adaptive equipment. Using an ergonomic chair with lumbar support can be used to promote posture when she's sitting for extended periods of time during childcare and any academic work. And she can utilize a wedge or pillows during sleep to sleep in a semi-reclined position. If this is comfortable for her, because it will address the pitting lower extremity edema and orthopnea.
Thank you, guys.
Thank you. Next, we'll have the students from the physical therapy department. Please come up. Where's the clicker? You have the clicker? Oh, is it down there? I think they put it down.
All right. I'm Shmuel Balasak. We're going to be presenting what PTs do in this situation with this patient. I start off with talking about what PTs do in general. So acute care and early mobility. We assess mobility and functional capacity during hospital stays. We monitor vital signs, heart rate, blood pressure, oxygen saturation, perceived exertion to ensure patient safety. Early mobility interventions such as bed exercises, sitting balance, and short distance walking depending on patient tolerance. Exercise prescription and monitoring. We develop tailored exercise programs focused on improving functional capacity, endurance, and strength while monitoring for signs of decompensation. Dyspnea, fatigue, and dizziness. We help determine safe levels of exertion using tools like the Borg RPE scale and 6-minute walk test. For functional training, we work on activities of daily living, transfers, and stair navigation if needed. We address balance and gait impairments that may be present due to deconditioning or injuries. We recommend assistive devices if necessary. With education and prevention, we encourage adherence to medical management, including medication lifestyle modifications. We teach patients how to follow precautions post-op, teaching patients to follow helm exercise programs. Lastly, manual therapy. We do soft tissue techniques such as massage, myofascial release, trigger point therapy, joint mobilizations and manipulations. Joint mobilizations are grade 1 to 4, and high velocity, low amplitude for manipulations. Nerve mobilizations like nerve glides, stretching and muscle energy techniques like prolonged stretch or PNF, and passive range of motion.
Oh, so for the role of PT for heart failure. So PTs are integral in assisting with early detection of heart failure exacerbations and can help directing the patient for proper medical care. So it's really important for anyone working in the healthcare field to know the signs of heart failure exacerbation. One being dyspnea, which is difficulty breathing, orthopnea is difficulty when lying flat, increased fatigue, that's like not typical of the patient's everyday activities, edema, fluid retention, in this case, so swelling in the legs. Any type of rapid or irregular heartbeat like tachycardia, it could signal worsening heart failure. Coughing or wheezing, especially if it's like pink or frothy sputum, can indicate pulmonary edema. Weight gain that's sudden and unexplained, often exceeding 2 to 3 pounds in one day. Decreased exercise tolerance, inability to perform their normal activities, as well as increased blood pressure, which high blood pressure could be a sign of the worsening heart failure. And cold, clammy skin shows like reduced blood flow to the extremities due to the worsening heart failure. And then confusion or altered mental status is reduced blood flow to the brain, which can cause confusion, dizziness, or other cognitive changes.
Okay, so clinical practice guidelines, or CPGs, are created by various healthcare organizations to assist PTs with clinical decision making based on a systematic review based on relevant evidence and to help manage patients with heart failure. So the main goal of CPGs, not just for heart failure, but for any diagnosis, is to provide PTs with evidence-based recommendations that assist in improving functional capacity and reducing hospital readmissions. So it helps with the standardization of care, helps improve patient outcomes, and it helps create a guided exercise or treatment prescription. As PTs, you want to be specific as possible with treatment for our patients, but this provides like a good starting point. We went over the facts of the case a bunch of times. As PTs, you want to focus more on the current examination and symptoms. Currently, our patient's ejection fraction is up to 45%. Current symptoms include dyspnea that is worsening, orthopnea, and significant lower extremity edema. She is currently in phase 1 of cardiac rehab, which is acute or the monitoring stage. Essentially making sure she's stable enough to be discharged from the hospital to enter the next phase of treatment. She is currently prepared for phase 2 of cardiac rehab, which would be subacute or the initiation of secondary prevention. She is most likely not going to receive a referral for phase 2, even though she is a good candidate, just because there are not many phase 2 cardiac rehab facilities available.
How's it going? So I'm going to talk about what we do as PTs in the hospital. And one thing we do is try to get a patient out of the hospital or where they need to go with the assistance they need. Can you hear me? Is this better? Nice. So one thing we do as PTs is figure out from a hospital where a patient needs to go. And so as I was seeing patients in the hospital, you would put first how many times you have to see this patient to achieve the goal you want. The first goal for this patient would be just to be able to ambulate 400 feet independently. And we add least needed assistive device because it's tempting to give someone just like a walker because it's really stable, but you want someone to walk with the least assist as needed so they stay as independent as they can and as strong as they can. Patient will demonstrate knowledge of the dangerous symptoms to look out for. I think patient education, we talk about it a lot and it's easy to forget and kind of skip over. And we always assume the previous healthcare provider like talk to the patient about what they should look out for, but I've seen patients post-amputation who have never been talked about, like about prosthetics or prosthetic options. So don't assume, always talk to your patients, especially about heart failure symptoms. The step goal is pretty much, it's a case-by-case basis. We're in New York. Sometimes you won't have to navigate any steps to get inside your house. Sometimes you will. If you need to navigate steps, we want to see you take steps in the hospital and see if you can do it by yourself. And then you want the patient to show that they can do the home exercise program you give them. A really nice way to find out if a patient's been doing their homework you gave them is walk in the room, say, hey, do you remember the exercise I gave you? And ask them to show you. And if they show you some random movement that you never taught them, you know they don't do their exercises.
So in terms of treatment, an article that we had read discussed 2 different algorithms to assess when it's appropriate to intervene with patients who have heart failure. So the first one is determining if the patient is stable using a red, yellow, green tool, which is the picture on the left. And it identifies specific symptoms for each. So green zone's all clear, yellow is proceed with caution, and red zone, medical alert, no exercise, you need medical attention immediately. This assists therapists and any other kind of provider to know when to seek emergency assistance. And then the second algorithm guides therapists on which interventions are most appropriate based on the factors like participation, endurance, and signs of exercise intolerance. It shows that therapy may not be necessary for patients who are medically compensated and physically active at the time, but for those who have participation restrictions or who are inactive, where physical activity should be encouraged, although someone is having symptoms of this heart failure going on. If there are activity limitations, the therapist should assess ability and determine appropriate interventions accordingly. And it's of utmost importance, like we talked about earlier, that you recognize signs of heart failure exacerbation, as well as be able to recommend timely medical follow-up to prevent further complications. As like all the disciplines discussed, it's not a one appointment thing. You have a lot of follow-ups that you need to go to. So this is important for early detection and management of the exacerbations.
Okay, for the treatment, there was most likely moved to cardiac rehab phase 2. With this one, it's PT supervised treatment. It's about 12 weeks, and it's for individuals recovering from a cardiac event. It's usually 4 to 7 times per week. And through this, they continuously monitor vital signs, mainly heart rate. And to determine the target heart rate, there's a formula to determine it. Once you determine it, you should you start at 60%, and every 2 weeks you should increase 5% until approximately 85% by the end of stage 2. What they mainly use is aerobic training. And for aerobic training, use treadmills, UBE, cycling, and rowing. You mainly want to use big muscle groups. You don't want to focus on little muscle groups. Don't want to really do bicep curls. It's not as effective. The types of aerobic training they can do is HIIT, high intensity interval training, circuit interval, and circuit interval training. Another way to monitor their heart is RPE, which is rate of perceived exertion. It's from a scale of 6 to 20. You just pretty much ask the patient, how hard do you feel like you're working? And for this stage 2, they should be between, in the beginning, 11 and 14, and later on from 14 to 16. Also in phase 2, they could begin resistance training. So they could use bands, dumbbells, pulleys, and weights. It's not like how, say, we would do it, where you would try to go to like 70% of how much you can usually do. They stay at about 30 to 50%. So if they could lift, let's say 10 pounds for this training, they're not going past 50. You're gonna start on the low end of 30. Like I said, to train bigger muscle groups instead of isolation. And this is when you implement a home exercise program, because insurance doesn't last forever. So you want them to start using what they learned in the clinic at home so they can continue working, getting better, and hopefully she can do all the rigors of being a new mom. That's it. That's all.
Thank you. Next, we'll have the College of Nursing. Thank you very much. Okay.
Good afternoon, everyone. My name is Lachelle Bryant.
And I'm Alona Posesto.
And we're going to be presenting on behalf of the College of Nursing, the APRN program. The other members of our group will be Erin Alton, Daniela Burke, Julia Dowdle, Juliet Marty, Narda Martin, and Erin Swan Ambrose. And we are future family and women's health nurse practitioners and nurse educators. And this is our presentation for Ms. Clark.
So as advanced practice registered nurses, we provide high level of care services, which includes diagnosing, treating complex illnesses, prescribing, and focusing on prevention and wellness through patient education. As FNPs, we can practice in the primary care setting or in the capacity of other specialties such as cardiology in this case. As women's health nurse practitioners, we can practice in the OBGYN outpatient setting. And with specific certifications, you can also practice in the inpatient setting, such as L&D or postpartum. The scope of practice and key roles for the responsibilities for Veronica Clark would be direct patient care, diagnosis and treatment, health promotion and prevention, and collaboration and communication, which is extremely important in this case.
So risk factors and disparities for African American and Caribbean American women. The first one being hypertension. We know that hypertension can increase the risk of preeclampsia and strokes in pregnant women. Of course, preeclampsia and eclampsia, we're at a greater risk of developing these conditions during pregnancy. It can also lead to gestational diabetes, which can cause macrosomias. Obesity as well, which increases our risk for gestational diabetes and increases the rate of cesarean deliveries. It can also cause preterm birth, which increases the risk of infant mortality and morbidity. There's also disparities, mainly the limited access to prenatal care. And all of these things are the reason that African American women have such a high rate of mortality. In fact, we are more likely to die from pregnancy. Oh, excuse me. Sorry. Is this better? Should I start over or did you hear it was good? Okay, thank you. So I'll start from mortality. So all of these things are the reason that African American experience greater mortality. We are actually more likely to die from pregnancy-related complications than our white counterparts.
So for her physical exam, at 34 weeks, she had mild fatigue, slight ankle swelling, and a grade 1 murmur. These are more subtle signs and symptoms, so they are commonly attributed to normal pregnancy. After delivery, that's when her symptoms worsened. By her 6 weeks postpartum visit, she had increasing fatigue, shortness of breath, and severe pitting edema. Her cardiovascular exam showed possible JVD, and her lungs had crackles, indicating fluid overload. The signs, again, were attributed to postpartum recovery, and this delayed her diagnosis, which doesn't help that our usual postpartum visits for postpartum women are 6 weeks after a vaginal delivery and 8 weeks postpartum for a C-section delivery. So that leads us to our differential diagnosis that we decided on. Our first one is our working diagnosis, which is peripartum cardiomyopathy. In this case, her pertinent positives were young maternal age, Black ethnicity, shortness of breath on exertion and fatigue, and peripheral edema and orthopnea. With her systolic heart failure, with her reduced left ventricular ejection fraction that was less than 45%. It often affects young women during the last months of pregnancy or in the early postpartum immune processes, nutritional deficiency, and hemodynamic stress of pregnancy or the postpartum period.
Our next working diagnosis was pre-existing structural heart disease. This simply means that the heart is abnormal structurally. Some pertinent positives is that she had a grade 1 systolic murmur at 34 weeks. She also experienced a worsening shortness of breath. She also was found with JVD and pitting edema. And lastly, she had crackles prior to pregnancy. The things that we did not see, which is one of the reasons we excluded this diagnosis, is because she did not have cardiac anomalies or abnormalities at 34 weeks. Her lungs were also clear at 34 weeks, and she does not have a cardiac history. Our third diagnosis, which again we also excluded, was preeclampsia-induced pulmonary edema. This refers to an elevated blood pressure during pregnancy that leads to fluid filling and building up the lungs. It causes shortness of breath and fatigue. So we know that she did experience some of those symptoms. She had a slightly elevated BP at 34 weeks, which could indicate preeclampsia. And she also had that BP that persisted 6 weeks postpartum. The reason that we were able to exclude this one is because she did not have proteinuria, she did not have severe hypertension or proteinuria peripartum, and she also did not have frothy pink oral secretions upon examination.
So for the management of peripartum cardiomyopathy, is similar to that of heart failure from other causes. A multidisciplinary approach is extremely important, such as referring to cardiology, whether it's an MD, PA, NP, once this diagnosis is suspected. The goal is to provide hemodynamic support and symptom relief. In the acute setting, we would be initiating first-line heart failure management, such as diuretics for symptom relief and by reducing edema and pulmonary congestion, such as Lasix. ACE inhibitors are contraindicated in pregnancy, but safe during the postpartum period, which in this case for Veronica would be okay. Beta blockers help reduce cardiac workload, but it's important to consider that they are safe in pregnancy and they are commonly used, but there may be a risk of fetal growth restriction. So if she was still pregnant or in future pregnancies, we would have to monitor the growth of the fetus by ultrasound. Also, aldosterone antagonists such as spironolactone are great for long-term management, but they should be avoided in the pregnant and breastfeeding patients. So we should identify if Veronica is breastfeeding at this point. Also super important as APRNs, education allows us to ensure that there's treatment adherence and lifestyle changes, also symptom monitoring and adequate response to possible deterioration. So as far as treatment adherence, is she compliant with her medications that are prescribed? Lifestyle changes. If she's smoking, we should advise her to stop smoking. No recreational drug use, diet modifications by reducing salt intake and limited fluid intake, which should also be considered if she's breastfeeding. Adequate response to possible deterioration. She should know when to contact the provider if she notices to begin that she uses more pillows when she's sleeping, or if her shoes are starting to fit tightly. A sudden increase in weight gain could mean fluid overload.
Thank you.
No, it's fine. Thank you very much. Last but certainly not least, we'll have participants from the School of Public Health. Please come on up. Thank you.
Good afternoon, everyone. I am Kadeen Waldron, and I'll be presenting today for the School of Public Health. Particularly, we'd like to consider what looking at a case study like this means for us in public health, how we would approach it, and how would it impact your fields. So when we talk about public health, so public health's primary purpose is fulfilling health promotion, health prevention, promotion, and particularly we're thinking of how to address population level issues. So for example, here we talk about public health providing maximum benefit for the largest number of people, whereas in clinical practice, you're working at an individual level. So we talk about the 10 essential public health services. So for public health, we're looking at things like policy, as well as institutions, as well as communities. In this particular instance, under assessment, we look at like health surveillance, for example. What kind of diseases are we seeing? What is the frequency in the population? How is it spread across? What demographic is it distributed across? And then when we see those trends, we then go on to investigate them and to understand why we're seeing those things. And so when we understand that in terms of, for example, through community health science or through epidemiology, through interviews, through research, then we go on to communicate what our findings are. So we're thinking, okay, here is this disease burden. So for example, in Mississippi, a few months ago, we had a large congenital syphilis crisis. And we were looking at why we were seeing such a large trend compared to other parts of the country. And if you looked closer, we were seeing lack of resources, closure of public health clinics, cutting the budget for public health care. And so those things were having a downward effect on the population. So when we find those things, then we're looking at, so how can we change that? What can we do about it? So we're looking to strengthen, to support it, to mobilize communities, as well as larger institutions and the government. And in doing so, we are trying to champion and to implement policies and plans to make sure that there are legislative actions occurring that are directly addressing the needs of the population, and not just one part of the population, but every part of the population. So one of the ways that we do so is utilizing legal and regulatory actions. And so, for example, right now we're seeing what the impacts of not having adequate public health legislation is looking like with the rollback of Roe versus Wade. And so, for example, in Texas, we're seeing a rise in sepsis cases because patients are no longer able to access abortion care. So things like that, like what can we do in terms of influencing policy, in terms of talking to legislators to make changes to impact the population's health. So when we are doing all of that, another thing that we're thinking about is, so if we do make these changes, how do we ensure that everybody's getting the same access or at least equitable access to those resources? And for example, when we had the earlier phase of the COVID-19 pandemic, we were seeing distribution of vaccines, or as well when we were thinking of the Mpox vaccine distribution, we saw that even though vaccines were available, there were some demographics who were having a better time at reaching those resources compared to others. In this particular instance, we saw Black and other marginalized communities having a harder ability to access vaccine care, even though they were sometimes right in our communities. But people from other communities were able to come in and get that care. So thinking about things like, are we using the right timing for offering these vaccines? Are we making sure that people feel comfortable coming to these specific community centers? All of those things are part of the considerations that we then research and then communicate to those who are doing policy work and to those who are doing clinical work. So you can have evidence-based and evidence-informed actions. So one other thing that we want to make sure that we're thinking about is who is doing that work? What does it look like in your communities when someone is getting healthcare? And we try to make sure that we're advocating for a diverse and skilled workforce because while every one of us is capable of providing services, sometimes we are better equipped to provide services to community members with similar backgrounds because there may be cultural understandings that we may have compared to others who may not have that, or the way that we speak to someone, for example. It might be okay for this particular group of people, but you may need a different type of training to engage with another community on that same conversation. And so finally, it's essentially a constant process. And so each level is informing the other and taking us backing to the other. So we're looking at improving and innovating through research and quality improvement. And for me, particularly, quality improvement is such an important aspect of what we're doing, because what is the point of the data if nothing changes? Okay, so this here further breaks it down in a way that we can better understand what the role of public health is. So as I mentioned earlier, we're looking at population level data, although that is not the only way that we perform our functions. Whereas in healthcare, you're talking to the patient themselves, you're understanding what their specific needs are, and you're trying to meet those needs. We also look at public health ethic compared to a personal service ethic. We think also as well as prevention or public health emphasis in terms of health promotion, for example, where we're actually trying to make sure that patients are being educated, but making sure that there's the resources to do that education, compared to where you on the clinical level, for example, maybe focusing on that particular symptom, that particular condition in that moment, and there's only so much that you can do. For example, you can't offer patient education if you don't have materials to hand out. So something else that we also do are joint laboratory and field involvement. So has anyone here seen the movie Contagion? Okay, so that's public health practice. So when we, for example, have a pandemic that's occurring, you try to identify cases, you're collecting data, you're doing surveillance essentially, and that information involves being in the field and then taking that information back to the laboratory, doing testing, and then communicating what we're seeing to make sure that we can do the right interventions. So I think some of this we already kind of covered in terms of talking about policy and legislation, so I'll just skip ahead to the case study. So here specifically, we're looking, as we talked about earlier, at a Guyanese woman. She's 29 years old. She's a graduate student doing pharmacy, and she complained about experiencing certain symptoms, but she herself dismissed her symptoms, and in turn, her clinicians also dismissed some of her symptoms. So in public health, some of what we would like to think about, jumping to here, is, okay, so on the individual level, so we know, for example, that she is a graduate student. She's in pharmacy, so she has an understanding of what clinical conditions may look like, what her symptoms could mean. And so the way that we speak to her might be a little different than the way we might speak to someone who has no engagement with clinical care whatsoever. But even in doing so, we then also have to come back to thinking about things like, so how does she address stress? How does she think of herself? How is she experiencing race in the country? So we can take that particular moment, race, and bring it out further to thinking about the interpersonal and the policy level, where particularly we know that people who are Black and who are women are far more likely to have their concerns dismissed in healthcare and are far less likely to be diagnosed on time, to experience cares and to experience delays in their care. And so this impacts their health outcomes. So we want to make sure that we're thinking both about how the patient themselves is engaging with her health conditions, but also what is happening in the clinical process. Do the persons who are doing their clinical assessments, have they had the right training in terms of, do they know how to speak to patients who are from the Caribbean? So for example, as a Guyanese myself, it's very unlikely for someone to go to the doctor unless something is actually very seriously wrong, and for them to express discomfort unless they actually feel very seriously ill. So knowing that, if someone comes to me, I would say, okay, this may be worth keeping track of for a longer period of time. So when you have like that kind of cultural understanding built into the work that you're doing, it helps to increase your efficacy. But if you can't do that, what are the kind of safeguards that we're building into our services that we can address missing those connections? So as our health informatics peers were talking about, for example, I mean, there's like AI flagging and so forth. But then we come back to the issue of racial bias once again, because who is creating the data, who is collecting data, all of those things are shaping the kind of data that we have and our ability to flag conditions. And even then, we still have to also consider the bias built into the design of our screening materials, screening tools. So one example that we can think of is the EGFR, which measures kidney dysfunction, essentially. At one point in time, this is something that we're finally seeing some changes on now, but Black patients were being rated at a different level compared to others. There was race adjustment occurring, and the race adjustment essentially meant that Black patients were seeing later diagnosis for kidney failure, and also then, of course, being later looked at for things like organ transplants. And so when you have that built into the tool itself, how then are you as a clinician going to be able to address the fact that your patient is suffering? Similarly, also another tool that is very commonly used, pulse oximeters. Does how many here know that we learned a few years back, particularly during the pandemic, that they are not as accurate for patients who are Black, particularly if they're darker complexioned? Okay, so not many of us knew that, right? So when we have these tools, they aren't always as accurate as we need them to be. So part of public health practice is finding these trends, finding these anomalies, and then going back and say, here's what we're seeing. What are the changes that we can implement in terms of on the program level or in terms of providing more resources that we can then ensure are there to improve patients' lives? So as we're talking, I just want to point out these particular anecdotes, but I think one that may be more familiar to many of us here is, for example, when Serena Williams had her first child, she released an interview later on describing her experience in giving birth, and that she had a pre-existing condition that impacted her pregnancy risks. And even though she had all this money, she had all these people who were advocating for her, the direction her pregnancy took, or her birthing experience took, was still almost one that cost her her life, because as a Black woman, she was not listened to during the birthing process. So here is some data to kind of emphasize what we're thinking about, particularly when we're talking about demographic impacts. So for example, Black women are 22% more likely to die from heart disease than a white woman, and 71% more likely to perish from cervical cancer. But we are 243% more likely to die from pregnancy or childbirth-related causes. So when we look at something so immense, 243% more likely to die from pregnancy or childbirth causes, that requires us to think some more about what we are seeing in both our practice, but also in the way that we're training, in the way that we are providing resources, and all of those things come back once again to public health practice. So here, I'd like to look particularly at one of the major lenses, one of the major paradigms for public health currently, which are the social determinants of health. So when we talk about the social determinants of health, we're talking about the non-medical factors that influence health outcomes. So for example, where were you born and what's your built environment like? What access to healthcare do you have and what is the quality of that access? Do you have economic stability? Those are the kinds of factors that we are growing better able to understand are impacting patient care, so that even when you have adjusted for socioeconomic status, for example, you may still see Black patients having worse outcomes compared to others. And so we want to keep that in mind when we are looking at case studies like the one that we're talking about. So for example, going back to the details of the case study, where the patient presented herself, where she described her symptoms, but even though the symptoms remained persistent, they were still dismissed as not particularly noteworthy, even though she had given birth and there should have been an improvement in her symptom profile. So something else I'd like to introduce to the conversation when we're talking about the SDOHs is also when you're thinking about structural factors, think also about colonialism and its role in how we perceive patients and how we respond to their needs. So for example, when we talk about indigenous communities, they're not in the data most of the time. We don't know very much about what is happening to them, what their needs are, and the only way to do so is if we care about them and go to them directly. But we don't have as much resource pointed in those directions. Similarly, when we talk about Black healthcare, so Black patients, even though we are very good at advocating for ourselves because we have to be, we are still seeing all of these negative, harmful outcomes, particularly because when we do express ourselves, when we do advocate for ourselves, there is a tendency to describe us as non-compliant, as difficult patients, as persons who are simply not interested in participating in a collaborative way with our own healthcare, and as thinking that we know more than the doctors involved. And I think it's worth keeping in mind, where do we get those ideas from? Even, for example, in the field of gynecology, one of the giants of the field that is still kind of venerated is a man who practiced experiments on enslaved African women. And so when you have that shaping your practice, when you have that shaping the education that you're getting, all of that is filtering down into patient outcomes, into patient experiences. And so coming back to the public health aspect of it, so one of the ways that we might want to return to improving this particular situation, is, like, for example, performing structured interviews with patients and with clinicians. For example, how was your experience with this doctor? Did you feel like you had space to describe your symptoms? Did you feel like you were listened to? And versus on the clinician side, so did you feel like you had enough time to listen to this patient? Did you feel like you had enough resources to address their needs? And so like things like that, those are all coming back to public health practice. Thank you.
Thank you very much. Okay, so that concludes the presentation portion of this afternoon's event. Now, as you can see on your table, you have a form with 6 questions. So we're going to give you all about 30 minutes to discuss amongst your groups, give input, think about what you learned today and any other ideas that you may want to contribute to this case study. So you have 30 minutes to look and discuss the questions on the table. Somebody please take notes from the table because we're going to have another 30-minute discussion where you can talk about some of the answers to the questions. Thank you.
So students, no, that's not supposed to go there, okay.
Hi, Dr. O'Hagan Murphy. Where is our assigned groups?
We have to click on the 4 squares that we have, and then it will give a choice of 4 rooms to join.
Yeah,
I think.
how do you tell where you're? Do you know where you're supposed to be?
No.
Okay, give me your names. I have a list here.
Katrina Brinkman.
What's the last name?
Brinkman, BRI.
And what's your first name?
Katrina, KAT.
Okay, Katrina, you're in group 4.
Thank you.
Who else?
Eddie Wu?
Eddie Wu?
Yeah.
Okay. Eddie, you are in, hold on. Group 2.
Thank you.
You're welcome. Anyone else?
Kristen Hall.
Someone is typing.
Is there somewhere we
Apple.
can see the groups? There's like 30 of us in here.
Yeah, so hold on, let me pull up your,
Just to save you some time too, you know?
hold on. Oh dear. Okay. Let me go through this. I'll just going to start putting you guys in groups. Give me a second.
Thank you.
I'll pull up my list and just do it manually, okay?
Sounds good. Thanks.
No problem.
Students. Students, can you hear me? Can
Yes.
anybody tell me online if they can hear me?
Yeah, we can hear you.
Yes, we hear you.
I'm going to read.
Gladys Sanchez, Jenny Lee, Melanie Tang, Rashonda Lockwood, Elke Kennedy, Francis Orlada, Sheila Cruz, Bintu Sumaro, Nisran Butala, Giorgio Spada, Vana Trong. That was group 3. Now I'm going to go to group number 4. Christina Chow, Melissa Pagaway, Claudia Appia, Alexandra Copen, I'm sorry, the names are
I'm
covered.
sorry, Professor Murphy.
Yes.
So right now, the only ones in this group in the main room are you, me, the main room that's talking, and Ama Aful.
Okay.
I don't have Ama Aful on the list.
Oh, okay. Let me see. I don't know. I'll have to check. Did she sign up to be in person? Hold on a moment. Okay, so everybody's got to their breakout groups. Is that what you're
Put
saying?
everyone in. I put everyone in their rooms already. Everyone's in their rooms except Aful. That's the only person because I don't have them on my list.
Okay, so if they're not, let me just check and make sure that how they signed up.
Okay.
I signed up.
But did you sign up in person or did you sign up for?
I honestly don't. I was trying to look back. I don't remember.
Hold on, I'm gonna tell you in a minute, and that might be the problem.
All right. All right. Can we have everybody's attention? All right. Half an hour is gone. So let's get back to the game. We have literally 5 questions. The 6th one is basically your recommendation, or whatever that it's going to be at the end. So you probably have a couple of minutes to basically spend time on any of these questions. So what we have in terms of a logistic, we have 3 microphones, one for the right side, one for the left side, and one for the center. So the first question is that looking at the patient, if you decide to discharge the patient, each and everybody's role in terms of the discharge planning and where the patient is going to end up going next. So we would like to start with people to volunteer for answering that question, and then we go around and spend about a couple of minutes on that question. Go ahead. Any table? All right. Level 6.
Hello. So our group, this is the answers we came up with. OT plus PT, they'll be in charge of the discharge for safety and transition. Health informatics, they'll be in charge of telehealth appointments, like follow-up telehealth appointments. DIM for echocardiogram. They're going to compare the 34 weeks heart sonogram, heart imaging compared with the 6 weeks urgent care image and 10-week postpartum image to see if the heart decreased in size. The PA, midwifery, and what was the other one? Yeah, RN, APRNs. Their plan will be to work up discharge ready, follow-up scheduling, medication management. In public health, they're going to relate demographics with the PT's primary CC.
All right, thank you. Do we have any other suggestion from any other group? Additional suggestion? All right, let's move on to the next. What are the top 3 concerns for this patient? Back in group.
Hello. Our top 3 concerns for this patient include start with mental health considerations. Number 2 is making sure that she's adhering to all of her follow-ups, because that's going to be really important. And then number 3 is going to make sure that she has access to all the resources that she needs.
Any other group? Any suggestion beside?
As exact risk factors and causes of this disease are not known, but there are a lot of studies show that PPCM could be caused by the fetal cell transfer through the placenta, which these cells are usually destroyed by the mother's immune system. But unfortunately, some of them, especially with weak paternal haplotype, they stay in the mother's system sometimes for decades, and they reside in the cardiac myosin, which and they can cause further episodes with the next pregnancy. And also there is a phenomenon that's called post-pregnancy surprise, because these fetal cells can interrupt mother's immune system and cause increased risk for autoimmune diseases and oncology, especially breast cancer. So this woman has to be consulted and monitored for those diseases as well.
Thank you. Any other viewpoints? All right, let's move on to the next. what's a broader perspective on enhancing health in this type of the patient's population? Back in there.
Okay, so for number 3, what is a broader perspective on enhancing health in this patient population? We said certain populations tend to get overlooked and often their symptoms are dismissed and explained away. Specifically in this situation, maybe somebody can simply explain what they're going through as a symptom of their pregnancy, but we can enhance health by providing resources and provide a proper understanding of the different healthcare professionals. So the different, for example, like explaining PTs and explaining OTs and explaining exactly what they do so that these patients can have a better understanding and get the proper treatment that they think is appropriate for them. Additionally, it is important to take their race into consideration and screen them for different morbidities that may be seen in these populations like we see in this one. And lastly, it is important that you are culturally educated on these individuals so that you can give a proper, the best quality of care for everybody.
Thank you. Anybody else wanna? All right, one in center.
Okay, so one thing that we discussed a lot at our table is the lack of trust in the healthcare system. So we think that in order for the mother to be compliant with any treatment, we're gonna have to reestablish her trust in the system because this is not your average young adult woman. This woman is educated. We know that she's in school for pharmacy. So imagine how she feels having some sense of education and she is still being ignored. So we think that that is something that needs to be addressed. Perhaps she could be partnered with case management or an advocate just to ensure that she trusts the system once again so that she is compliant with any treatment that we give her.
Thank you. Any other viewpoints? All right, let's move on to the next. Right there, sorry. Didn't mean to.
I was just gonna add on to what she said. I think specifically talking about the practitioners that go within the home. This is now, we're entering a safe space that we were technically never supposed to even be there in her eyes, and now we have to be there to provide her care. So as OTs, PTs, and even like home RNs, we have to take that into consideration, and any like home exercise program that we're providing, any treatment that we're providing, we're taking time and pacing it so that we are allowing her space to communicate how she feels throughout the process. So that is not only making her feel safe, but like having her trust to build rapport with us that we have like the best interest for her, not only as just like her health, but her as an individual and like seeing her for a human being.
Thank you. Any other viewpoint? All right. Question number 4, what advocacy is needed for this patient client, local and community-wide, and how does one or we have access to it? All right, there are a couple of people back there.
Hi. So we selected for advocacy and resources the use of implementation of a midwife, a doula, social work, and case management. Also, community-based support groups for postpartum women with history of cardiac issues, and mental health resources.
Go ahead.
Okay. Hi, everyone. Good afternoon. Okay. So we said for number 4 that Veronica having social workers, occupational therapists, also mental health counseling, so like psychotherapy, also having like a postpartum doula, and also access to midwives would be beneficial for her. in order for her, she can also use like community-based organizations. One of them is the Caribbean Women's Association that's located here in Brooklyn. She can be able to use that to be able to get like doula and also immigration support because she is from Guyana. And then not only that, but also she can use that to access like community resources.
Can you use your microphone closer to your mouth, please?
Sorry.
Thank you.
She can use the Caribbean Women's Association to be able to access like community resources, immigration support. Also, a doula who'll be able to really walk her through this process and serve as a great help to her. She can also use like her because she is a student. She can use her university again, like for more resources, or also using like the counseling center at her school. And then also we also said that after this process, building like preferably an interdisciplinary team like within the same institution. So the same hospital institution would be really beneficial for her because it'll be able to keep track of her progress like postpartum and also keep all her health records together. So different healthcare workers that see her, they will be up to date and up to speed on the different on her various conditions.
Thank you. I guess that we were on number 4, but she mentioned some of the number 5. But let's look at the number 5. What facility exists to help client with patient-client special problem issues, and how can patient-client access them? So that's number 5, question number 5. If anybody has additional viewpoint, please just mention that.
So we could connect her with, is it Healthy Start? This program for first-time moms to have a visiting nurse. Essentially trying to connect her with things that are affordable and accessible to her. Thought of something else and now I'm gonna forget. Damn, I forgot. We'll come back.
Any other viewpoint?
So the question is, what facilities exist to help with any special problems, issues? We wrote down introducing the patient to some free clinics that surround her neighborhood. She mentioned one, like the Caribbean Women's Association. Also, as a health informatics major, just training the patient on the usage of telehealth, right? So that she doesn't have to always go in somewhere to get patient care, that she could do it from her home or from her cell phone. That's another thing we wanted to add.
Any other viewpoints?
Just another quick pointer, we would recommend offering a lactation consultant. She is a first-time mom, so it would be important for her to have a little easier time with breastfeeding, and sometimes the extra help of a lactation consultant can help her with how to navigate that new journey.
Thank you. Any other viewpoints? All right, let's look at the last question. Any new items you discuss, or what did we miss? So anybody want to take on that?
Hello, we also decided nutrition is a huge part in this as well. So like she needs a nutritionist. Also, since she is a first-time mom, if she doesn't have a pediatrician for the child, because we have been focusing on her, but it's 2 individuals in this case as well. And I think therapist was discussed as well. So thank you.
Thank you. Any other viewpoints? There were a couple back there.
So we just have we have like 3 more stuff. So one, how does this impact her immigration status, considering the fact that she is from Guyana? So we don't know if she probably is here on a student visa. So if she is on a student visa, this childbirth process of hers would then most likely have to extend her student visa. So we also have to take into consideration what type of insurance does she have. That's also a really big issue as well too. And when she does need to be able to get access to following, following care, will they be able to accept the type of insurance that she has? Or if she doesn't have insurance, that's another issue too. And also, like I said before, like how she's a student, how will this impact her education? Because she is studying pharmacy, will she have to take off time from school? So these are all different things that could impact her childbirth experience.
Thank you. Any other viewpoints?
Thank you. Okay, I remembered. Sorry about that. Um, so alongside that idea, she's in grad school. We want her to go to all these extra appointments and receive people at home and doulas and lactation consultants. Like, who got time for that? So figuring out on top of, does she have some kind of maternity leave? Is she also working at the same time? Can we write her a letter in order to get her on disability so that she can extend that leave? Because our parental leave in New York State is horrible. So in this whole country, honestly, she is not going to recover from this condition in the 6 weeks that she might have. So making sure that she can get some time off from school and work and be able to do those things, and understanding that that should be her priority right now, and get her some financial assistance so she's able to do that.
Thank you. Any other viewpoints? All right, one in center.
Because this happened at a hospital, I feel like the hospital department directors should come together and discuss this patient's care and how this misdiagnosis happened and how they can prevent it from happening again to other patients.
Okay, thank you. All right, we have another one.
I would say that to piggyback off Faria, there should be some sort of a thorough documentation. And as a health informatics professional, we speak about shared decision making a lot in the curriculum. So not only should the provider have immense experience and knowledge, but the patient should also take care of their own health as well, and should be looking forward to that.
Thank you. One in the back.
All right, the last thing we wanted to say was, does she have familial support? The case study just stated she's a student from Guyana. Is she here alone? Does she have other family members? Because that's like a lot of moving pieces in addition to trying to like maintain status in school. So that's something we also did not address.
Thank you. Any other viewpoints? Anybody? All right, thank you very much. Great viewpoints. We all learn together. We have Dr. Adi Jumbo to just make the closing remark.
Wow, wasn't that wonderful learning that you guys did today? Yeah? Give yourself a round of applause.
Thank you for doing this. It's the last one I'll be doing.
Huh?
It's the last one I'll be doing, so thank you.
Oh, really? Should I?
Oh, wow. Well, I don't know if I should break the news. Mr. Bond said this is going to be the last event he's going to help us to coordinate. So please give him a round of applause. He's been doing this for many years. I also want to use the opportunity to thank you guys, because I've learned a lot. As a faculty member, I've really learned a lot across the board from all the programs. So give yourselves again a round of applause. Come on, guys. Be happy. Come on. I need to hear more. Great. All right. So just a closing remark. Thank you so much for coming. especially those of you that made it here in person because it's very important, right? You can see how, across the room you have different students from different programs. You made it, wonderful. Also time to learn together. As Dean said, it's very important to learn interdisciplinary, right? Because once you leave here, you're going to learn to work together, right? Patient care is not about just one discipline alone, it's across the team. So thank you for coming again and making it a success. I also want to use the opportunity to thank the faculty members, the interdisciplinary case study faculty members. Thank you guys from nursing, public health, School of Health Professions, and all across the board. Thank you so much. And you're free to go.